Pour la 5e année consécutive, le Forum Ghalien Afrique se déroule en terre sénégalaise du 6 au 9 décembre 2022. Le Forum Ghalien Afrique offrira une plateforme d'échange exceptionnelle autour du thème « Accélérer la marche de l'Afrique vers la couverture sanitaire universelle ». Placé sous la présidence effective de son Excellence M. Macky Sall, président de la République du Sénégal, le Forum Ghalien Afrique réunira des experts scientifiques des secteurs de la santé, de l'économie, de l'environnement, d'éminentes personnalités politiques et de la société civile, d'anciens récipiendaires de prix Nobel, des universitaires et des centaines d'étudiants en médecine et pharmacie, ainsi que des jeunes innovateurs. Cette 5e édition du forum, avec 1500 participants, sera organisée en format présentiel et virtuel avec, du 6 au 9 décembre 2022, un forum des jeunes, un forum des femmes et un forum scientifique. Le vendredi 9 décembre 2022 se tiendra une cérémonie en présentiel au cours de laquelle, pour la seconde fois, le prix Ghalien Afrique, qui consacre la recherche, l'innovation, la santé et la technologie, sera décerné. Du 6 au 9 décembre, le Forum Ghalien Afrique fait de Dakar la capitale africaine de la santé, de l'innovation et de la recherche.
Alors, Dr John NKENGASONG est ambassadeur itinérant et occupe le poste de coordinateur mondial de la lutte contre le sida et de représentant spécial pour la diplomatie de la santé au département d'État américain. Donc, à ce titre, Dr John NKENGASONG supervise le plan présidentiel d'urgence d'aide à la lutte contre le sida, PEPFAR, qui constitue l'engagement le plus important jamais pris par une nation pour lutter contre une seule maladie, prévenir des millions d'infections par le VIH, sauver des vies et progresser vers la fin de la pandémie de VIH-Sida. Auparavant, John a été le premier directeur des centres africains de contrôle et de prévention des maladies. Donc, sous vos applaudissements, je vais pas lui. Alors, à côté de lui, nous avons comme panéliste le professeur Edwin Alfred Yawson. Il n'est pas là. Ahmed Ogwell OUMA. Monsieur Ahmed n'est pas là.
Il est là. Il est ici.
Ok, d'accord. Professeur FAWOLE. Très bien. Professeur Jean-Jacques Mouyemba. Je pense qu'il est en ligne, il sera en ligne.
Il est en ligne, c'est confirmé?
Oui, je pense. Et monsieur Chris ELIAS et le docteur Ibrahima Socé FALL. Docteur John, vous avez la parole.
Thank you so much. It's an honor to be back in Senegal. Always, as I told Professor Awakosek the other day over the phone, that when she says we should come to Dakar, we all come to Dakar because we like being in Dakar. But it would really be helpful to get more people in because this is going to, I see so many people are still out there for coffee. Just if protocol can get them, signal them that they should come back in, that will be very, very helpful so that we have an exciting conversation. We're truly honored to have a list of a very strong panel that the co-chair had already mentioned. So without much ado, let me start with the first question. And I'll ask that because we are about 5 or 4 on the panel, that we make maximum use of our time. So let me start with the first question to Dr. Ahmed Ogwell OUMA, who is the Acting Director of Africa CDC. Dr. Ahmed, can you share your experience during this COVID? We want to say that we want to believe that the COVID is, that we've moved on, but we know COVID is still around. What are the major lessons that we've learned from the COVID pandemic? And how is that related to the universal health coverage? What is your views on that? I think we'll just follow that trend and then go down. I'll ask that we keep our comments brief so that we have an opportunity to go around, do a second round, and then maybe just get questions from the floor. It would be very good to get 1 or 2 questions from the floor. So, Dr. Ahmed, the floor is yours.
Thank you. Thank you very much, John. And first is to really thank the team.
Your microphone, just punch.
Yeah. That's good. Yeah, to thank the Ghanaian Secretariat led by our COLSEC for putting this very good meeting for us to be here today. Now, in relation to universal health coverage, the lessons that I'll share 3 lessons in as far as this COVID pandemic is concerned. One is the heavy disruption to routine health services. We have very few staff on the continent, and the same staff were not only expected to do routine work, but they were also expected to respond specifically to the COVID pandemic. And this resulted in a lot of disruption to regular health services, which results we are seeing now in terms of increased, for example, outbreaks of vaccine preventable diseases like measles, and the health systems has not yet recovered. So this is one thing. Second is the resources that will be expected to be used in other parts of the health system, apart from the staffing. The other resources have also been affected because they were shifted to get PPEs, to get vaccines, to pay for rapid responders. And this removed from the existing healthcare needs. And this too has resulted in quite a significant disruption in achieving universal health coverage. The third is with the public, that there was so much miscommunication and sometimes outright wrong information that has been shared during the pandemic, that it has resulted in difficulties by the public in keeping the faith in public health, so to speak. And we need to do a lot of reflection on how we keep the public informed with the right information in a timely manner, so that misinformation does not take root, because that affects the rest of the health system and will also affect universal health coverage. Going forward, really the 2 things we need urgently, one is to have standby resources to address emergencies, so that the whole health system does not get disrupted. And these standby resources will be human beings, it will be infrastructure, it will be money, and we must find a way of ensuring that those are available. And the second thing that we need to do is we must build legal instruments, agreements that actually speak to the needs of public health emergency today. We have some agreements that were negotiated in the past. There are gaps, we need to fix those. There are new agreements that are coming into play. There are gaps because if we don't do things differently, if we don't deliver the resources out of those agreements in a different way, then we are not going to achieve different results. So any agreements, any tools, any resources that are being made available, they need to be made available with the lessons of COVID-19 so that we can be able to achieve different results going forward. Back to you, John.
Thank you. Thank you. Absolutely. I think a lot of lessons learned from COVID. And let's hear from Professor FAWOLE, your experience in Nigeria. If you heard what Dr. Ahmed said, and how, if you could just describe your experience in what you saw in Nigeria during the pandemic. Yeah. And I can't believe we are here today using words as if the pandemic is over, which is true. I mean, the fact that we are here already physically means that we've made a lot of progress. It's not over, but we are at a very different place. But what was your experience in Nigeria, or has been your experience in Nigeria?
All right. Thank you very much, moderator. And I want to stand on the existing protocol already established by my predecessor and thank the organizers for inviting me to this auspicious meeting. Certainly, we know that COVID-19 affected the provision of essential health services. And by essential health services, I'm talking about things like antenatal care, outpatient attendance, and routine immunization. And many of these things went down in many health systems. But fortunately, the Federal Ministry of Health in Nigeria, in conjunction with the GFF and Exemplars in Global Health and the University of Ibadan, conducted a study to know how subnational systems were resilient during the pandemic. And the premise for this was that if we understand the challenges these health systems experienced, and we learn the lessons from it and how people or subsystems overcame their challenges, then we'll be able to inform policy decisions in the future. So a mixed method study was done, and the targets were sub-national managers at state, local government, health facility, and community level. And we had many key learnings from this research. And the key learnings were that at the state level, things were not too bad. They were able to have and maintain strong collaboration and coordination. And they did receive a lot of support from the federal government. And therefore, they were able to do testing and surveillance, refer cases, and adapt as the pandemic went on in its various ways. So that was a good lesson that they could adapt. But at the local government level, even though there were adaptations too, and the local governments tried to engage the community and shift task, but there were still some disruptions. What we learned here was that two groups of local governments emerged. The high performers who were able to rebound quickly and after the pandemic, and the comparators who were not weak, but they couldn't adjust back to pre-pandemic levels as fast. But the characteristics of these high performers that make an important lesson for us is that these local governments they had strong leadership, they were well coordinated, they monitored trends which guided their activity. They had funding, they had resources to adapt, and these resources they used particularly to engage the community members. And they worked or took advantage of their existing collaborations at community level with traditional leaders, religious leaders, opinion leaders, to ensure that they expand their community networks and conducted outreaches. Bringing it down to the basics, they were able to take PHC to the community by carrying out routine immunizations, visiting pregnant mothers. But the key lesson that we would learn from that, the take home for epidemic preparedness and health system strengthening in the future, is that we need to maintain our routine health services during periods of disruption to ensure that things are going on very well, particularly the provision of essential health services. And we need to be adaptive and engage the community. Community engagement, very, very crucial, because that was responsible for the success stories of these successful NGE. Particularly is human resource, which my predecessor has already mentioned, that we need to have the human resource capacity, because this was that was what brought down the comparators LG. They didn't have the capacity. There was already a shortage. And when the pandemic hit, then they even went further down. So having the human resource capacity and being able to surge in times of disruption is very, very crucial. I'd like to end on this note. Thank you.
Yeah, thank you. Well, thank you for sharing the Nigeria experience with us. We'll come back to you. And just to prime you that I would like to hear, when we come back to you, your experience at the university. How can universities be better positioned to address future pandemic? But we'll come back to that. Let's go to Chris. Chris, your organization, the Bill and Melinda Gates Foundation, was at the fore of this, the fighting this pandemic, the COVID-19 pandemic. And I will personally say that in my previous role as the head of the Africa CDC, your organization was the first to rally around and provide funding of 5 million to start the diagnostic program on the continent. Now you are 3 years into the pandemic. If we were to do it, how would you do it? How would your foundation approach this, given all the experiences that you've seen both with the Africa CDC, WHO, and other funding or other support that you provided during the pandemic?
Thanks, John. Yeah, I don't think it's accurate to say that the Gates Foundation was at the fore. We tried to exercise the flexibility we have as a philanthropy to be catalytic, to move quickly, and as you referred to, our early support of the Africa CDC in January of 2020 was an example of what was a modest contribution, but a quick contribution that allowed that important institution to begin to move quickly. We did the same with WHO, UNICEF, many of our other partners, but in the end, it was African countries that were at the fore of the response to COVID-19. And I think that there's a couple of lessons to learn in terms of the theme of the Gallian Forum on universal health coverage. And I think Ahmed and Professor FAWOLE have actually touched on those. One is that we have been inadequately supporting health systems, particularly primary healthcare systems, so that even in countries where they were sufficient, they were not resilient enough to withstand a challenge that challenged us across all three of the pillars of universal health coverage. It challenged us in financing. Fortunately, Africa didn't see the very high mortality, per capita mortality rates that we saw in the United States and Western Europe. But the economic disruption that came actually before significant increases in cases distracted budgets, reoriented budgets so that the financing for systems were stretched. The out-of-pocket costs, which are already too high on a day-to-day basis, went up for many people, particularly the poorest people who were least positioned to afford it. Secondly, as you mentioned, it affected the quality of services. We asked frontline health workers and other health professionals throughout the health systems who were barely sufficiently staffed to do a lot more, to don PPE, to take care of very sick patients, and to not lose track of the essential health services that are critical to the success that we've seen over the last 20 years in our progress against the MDGs and now the SDGs. So we saw significant declines in routine immunization, significant increases in many places in maternal mortality. We saw fear of people being afraid to go to health centers because of this new emergent disease, and so therefore, not seeking timely care. And what I think was most challenged in terms of universal health coverage was the inequity. Professor FAWOLE just mentioned this, that some places that she's been able to identify through the exemplars were rebounded pretty quickly, but many places struggled in that rebound. And so I think as we think forward, we have to think not just about what's sufficient for today, but what's actually the resilience that we need to be challenged, because we're going to be challenged, whether it's another flu pandemic, whether it's an outbreak like we've seen recently in Uganda with Ebola. We're going to have to build a much more resilient system. So the Gates Foundation is thinking through, we have a significant amount of our focus is here in sub-Saharan Africa. I was just with Bill Gates last month in Nairobi, where a bit like Professor Kolsek was talking about this morning about the engagement of youth, Bill hosted a town hall interview with 500 students at the University of Nairobi. And in there, he talked about the foundation's historic commitment to Africa and actually projected that over the next 4 years, we're likely to increase that commitment and And the figure he mentioned, which I think is conservative in terms of what we'll actually do, was that we'll probably program $7 billion on the continent over the next 4 years. We do that through a variety of important partnerships. So the Global Financing Facility at the World Bank, which is a sponsor of today's scientific forum, we're one of the major donors there. They, I think, did a good job during the pandemic of responding with specific grants to countries for encouraging the reestablishment or regaining the essential health services. We've just recently recommitted with a 20% increase in our pledge to the most recent replenishment of the Global Fund. And the Global Fund has a significant amount of its resources targeted to building resilient systems for health. And similarly for Gavi, where focusing on regaining the losses, almost decade type losses in routine immunization will be important. Will there be an important a conference tomorrow convened by President Macky Sall on immunization and polio eradication to help focus on that important need to regain immunization losses. So we'll continue to work with the groups, those partnerships we've worked with for a long time, but increasingly with important partners here on the Africa continent, groups like the Africa CDC, groups like the AMREF in Kenya, where we've been working in a variety of countries, and increasingly putting that focus on national institutions, because to go back to my main point, I think the people who were at the forefront were the governments and institutions in the countries, because COVID showed us that the global institutions and rich countries can be easily distracted when they face their own crises. And so I think this renewed emphasis on building the capacity of African institutions, investing in the next generation of African scientific leaders, as Dr. Kolsek was discussing this morning, is going to be, I think, a key component of how we go forward and build that resilience that we need in the system so that we don't suffer as much of a setback next time that we're faced with an acute crisis. Over.
Thank you. Thank you, Chris. I think we all agree that the best time to prepare for the next pandemic is to start preparing today, because it will definitely be another challenge. Socé, vous êtes le directeur général adjoint de l'OMS en charge de la réponse aux urgences. Quelles sont les plus grandes leçons de gestion de cette pandémie? Est-ce que vous pouvez partager votre expérience personnelle?
Merci beaucoup, John. Je voulais tout d'abord remercier le professeur Kolsek et toute l'équipe du Forum Galien pour l'invitation. C'est une rencontre extrêmement importante pour moi et pour tous ceux qui sont engagés dans la santé mondiale. Parler de leçons apprises, je parlerai plutôt d'enseignements tirés et de leçons écrites. Je ne suis pas sûr que les leçons soient déjà apprises. On verra plus tard dans la mise en œuvre de toutes ces leçons si elles sont réellement apprises. Et tout ce que je vais dire aujourd'hui n'est pas nouveau. Mon frère assis devant le répète tous les jours. Nous le répétons tous les jours. Et la vie de l'humanité est ponctuée de pandémies, mais on est tout le temps dans ce cycle de panique et de négligence. Quand il y a une pandémie ou une grosse épidémie, urgence sanitaire, tout le monde se mobilise pour investir et finalement, on retombe dans l'oubli et on tombe dans notre routine. Mais la pandémie a révélé donc notre incapacité en tant que communauté, en tant que société, à collectivement travailler ensemble pour faire de la prévention, de la préparation et répondre de façon efficace. Et clairement, nos systèmes économiques, nos économies qui sont interconnectés sont très fragiles et l'inéquité qu'on retrouve dans nos sociétés, l'inéquité, l'inégalité entre pays, mais aussi à l'intérieur d'un même pays ont permis donc à ce virus d'évoluer très facilement et que les plus vulnérables soient encore plus exposés. Et dans le cadre du travail justement que mène donc à ses collègues dans ce qui est appelé le Conseil mondial de suivi de la préparation. Des alertes ont été lancées depuis très longtemps. Quand on regarde le rapport de 2019, d'avant la pandémie, qui disait clairement que le monde n'est pas préparé, le monde n'est pas prêt. Et malgré donc ces alertes et le risque d'une pandémie qui était déjà, le risque était imminent parce que tout le monde voyait les facteurs essentiels tels que la déforestation, la perte de la biodiversité, l'urbanisation galopante, donc les voyages internationaux et tout. Et nous avons parlé pendant longtemps de la maladie X parce qu'on ne savait pas quel serait le virus. Et malgré ça, il n'y a pas eu suffisamment d'investissement pour préparer donc, nos sociétés. Et on parle de leçons tirées. Donc, je pense que le premier point que je vais aborder, c'est le leadership politique. Le leadership politique fait toute la différence. Quand les leaders politiques se basent sur la science, sur donc, les connaissances, les bonnes pratiques pour prendre des décisions et protéger la population, on voit très clairement la différence. Mais quand les décisions sont déterminées par d'autres facteurs purement politiciens, il est difficile d'avoir donc la différence. Et ce leadership politique ne doit pas commencer pendant la crise. Il est important donc de planifier à l'avance, d'investir dans la préparation et à travers donc tous les secteurs du gouvernement, parce qu'on ne peut pas faire de la préparation uniquement par le secteur de la santé. Et il est important donc que des investissements conséquents domestiques soient donc alloués à la préparation et à la protection de la population. Et le deuxième point, c'est que la préparation ne s'arrête pas aux actions du gouvernement, tout part de la communauté. Et il est important donc qu'au niveau individuel, qu'au niveau collectif dans la communauté, que l'action de préparation et de protection soit bien planifiée et bien organisée, de telle sorte qu'on peut anticiper la réaction de la population, qu'on peut construire cette confiance entre la population et les autorités, donc bien avant les crises. Le troisième point, c'est que l'impact crise sanitaire va au-delà du secteur sanitaire. Nous avons vu l'impact socio-économique et les conséquences sur la vie de nos sociétés. Donc, il est important dans les actions de tenir compte donc, de ces effets qui vont au-delà de la santé, dans la préparation déjà, pour anticiper ce genre d'effets. Et les mesures, le prochain point, c'est que les mesures actuelles de préparation ne permettent pas d'anticiper et de prévenir les crises sanitaires. Je pense qu'il est important de le dire. On a vu plusieurs groupes essayer de classer les pays sur la base d'index et d'indicateurs qu'ils ont tirés de l'évaluation externe des capacités. Mais aujourd'hui, on ne peut pas avoir juste des systèmes statiques pour déterminer le niveau de préparation. Nous avons besoin de systèmes dynamiques qui permettent de tester les systèmes réellement, de les exposer, de voir là où sont les failles. En utilisant une approche de risque et vulnérabilité, de façon dynamique, nous pouvons mieux préparer les pays et le monde à réagir. Et le point important aussi, c'est le retour sur investissement. Quand on investit dans la préparation, on est beaucoup plus efficace. Et quand on parle de millions de dollars dans la préparation, on parle de milliards de dollars dans la réponse quand on regarde la pandémie COVID-19. Donc, si on avait bien investi dans la préparation, on aurait pu protéger nos économies et sauver donc beaucoup plus de monde. Et finalement, l'impact sur la couverture sanitaire universelle et nos services de santé. Nous avons effectué une étude sur la surmortalité durant la période de la pandémie, donc entre janvier 2019 et décembre 2021. Alors que les rapports officiels nous parlaient de 5 500 000 décès, nous avons vu qu'il y a eu pratiquement 15 millions de décès qui sont parfois directement liés à la COVID-19, mais parfois à l'interruption des services de santé parce que les gens n'ont pas eu accès aux services de santé, que ce soit pour la chirurgie, par exemple, les gestes de chirurgie ont été réduits de 60%. On a vu que 18 millions d'enfants n'ont pas été vaccinés en 2021. On a vu que le nombre d'enfants à 0 dose qui n'ont jamais reçu aucun vaccin a augmenté par 5 millions. Donc, voilà la situation qu'on voit et j'espère que ces éléments vont réellement être des leçons apprises et changer notre manière de faire de la préparation et de financer la réponse aux pandémies. Merci.
Thank you, Socé. I think everyone has agreed that there's always a circle of panic and neglect when we deal with pandemics, and we should get over that and invest showed a lot of return on investment. When we put in a little bit in preparedness, it can save us a lot. So rather than put a lot in response. I would like to, we'll go down and do a second hearing from each of the panelists, but I would like to open this to the floor and see if there's any reaction. How are we, based on what you've heard from the four speakers, if there's any reflection or comments, and please feel free to direct your comments or questions to any of the four speakers. We'll take two questions from the floor, then go back to the panel to get to get them to respond. Yes, please, just say who you are and direct your question to the specific, and use the microphone if it's possible.
Allô, bonjour. Je voudrais remercier les membres du panel pour les brillants exposés. Je m'appelle Eladji Gorgui Wade Ndoye, je suis journaliste sénégalais accrédité auprès des Nations Unies à Genève. Ma question est adressée à M. Socé FALL. M. Socé FALL, dans votre exposé de tout à l'heure, vous avez parlé d'un rapport qui a été fait, d'ailleurs commandité par l'OMS. Et on sait que votre rôle, vous, en tant qu'OMS, c'est de faire de sorte que l'humanité soit en bonne santé. C'est ça? Alors, je sais que Eladji Assi, qui est en face de vous, a travaillé dans ce rapport-là. Il aurait été intéressant aussi de l'entendre, même s'il se cache toujours. Bon, la question, M. Fall, vous avez parlé du rôle des États. Vous avez parlé aussi de la nécessité de l'implication aussi des citoyens eux-mêmes dans la prévention, mais aussi dans le traitement nécessaire quand les maladies ont lieu. Ma question, c'est de savoir pourquoi nos États n'écoutent pas. Je vous remercie.
We have a hand here in front, and then I think is, okay, please, since you have the microphone, go ahead.
Thank you very much. My name is Robert Ajako with the African Risk Capacity. My question is to, I think, all the panelists. We spoke about the importance of looking at routine services while responding to outbreaks and epidemics. We have the knowledge from the Ebola crisis where we lost 100,000 people directly to the Ebola crisis in West Africa, about 10,000 thereabouts to routine services, missed opportunities for immunizations and co. Same has happened during the COVID pandemic. My question to, I would say the head of CDC and others is, what do we do to ensure that we keep an eye on routine services while we are dealing with pandemics and outbreaks? Thank you very much.
Bonjour. Bonjour, c'est Dr Annie Ménagère. Je suis médecin et expert en protection sociale et aussi innovatrice dans le domaine de l'intelligence artificielle. Ma question à M. Chris Elias, je vous salue pour votre dynamisme dans le domaine de la prévention. Et je vous demande, est-ce que vous ne comptez pas travailler sur l'anticipation à travers l'intelligence artificielle de l'avènement des épidémiologies, des épidémies comme ça, vous pouvez vous préparer en certains des dispositifs de prévention. Est-ce que ça ne serait pas un petit peu plus efficace que de voir venir et commencer à travailler sur les mesures de prévention, notamment les vaccins? Et merci beaucoup.
Okay, good. We'll take the last question here, then we'll go to the panel.
Thank you very much. My name is Paul Lalvani. I'm the Executive Director of Empower School of Health. The question I have for a few of the panelists is, when we talk about pandemics, when we talk about emergencies, one of the biggest challenges is, how do we protect the frontline workers? How do we give them the necessary knowledge and information rapidly when things are changing so rapidly? products are changing, policies are changing, the people that need to respond are changing as well. We have some experience in Asia when we worked with WHO across multiple countries, but I would love to hear in Africa how Africa CDC or Senegal or perhaps even Nigeria, what were your experiences and how you managed to inform and educate the frontline workers? Thank you.
Okay, good. So thank you all for those questions. I think this is open to the panelists. We'll start with Socé, since the first question was addressed to you, then Chris, and then we go to Ahmed.
I will start in French for the first question from Gorgé. Non, merci Gorgé. Pourquoi les États n'écoutent pas? C'est une question très intéressante et qui nous ramène au cycle de négligence et de panique. Quand les États paniquent, ils écoutent. Je ne peux pas vous dire le nombre de coups de fil que je recevais à un moment donné. Mais quand les États sont revenus en confiance dans leur routine, le nombre de coups de fil s'est réduit clairement. Et je me rappelle qu'à Genève en 2019, je vous montrais les rapports préparés par As et ses collègues pour vous dire que le monde n'était pas préparé, qu'on était à risque. On n'était même pas encore dans la pandémie. On parlait d'autres épidémies en général. Et je pense que nous devons utiliser cette fenêtre d'opportunité qui est très réduite en ce moment pour que les États écoutent. Et je pense que les chiffres sont là pour le montrer qu'ils ne peuvent pas avoir la prospérité économique si on n'a pas un investissement conséquent dans la santé et dans la protection sanitaire. Et quand on regarde, qu'on compare au secteur de la sécurité et de l'armement, les États n'ont pas besoin d'être convaincus. Ils le font tout seuls parce qu'ils veulent se protéger. Il faut qu'on arrive à ce niveau et que nos États décident de protéger la population, de protéger l'économie en investissant dans la santé. And the second question from Robert Ajako on, routine health services. This is a very important question, and this needs also to be taken into account during the planning stage for preparedness. We need to make sure that we have, all the mechanisms to scale up our capacity to respond to pandemic and epidemics while making sure that we continue to deliver critical services, because sometimes it's just a matter of even, leadership and decision. I have seen in a country where they stopped vaccinating against measles because they just wanted to vaccinate against COVID. It's just nonsense. You cannot do that. We need to make sure that we continue protecting people from other conditions. And that's why if you look at the excess mortality, more people died because of the indirect consequences of the pandemic than direct consequences of COVID. So we need to make sure that when you activate emergency mechanism in a country, the system continue to work. And secondly, we cannot deal with, infectious disease today, and tomorrow we'll deal with non-communicable diseases. We realize that so many people didn't know even that they had diabetes. It's just because of COVID and the complications, they realized that they had diabetes. We need to make sure that we have integrated services and the person is at the center of the healthcare. It's not about looking at one disease or two diseases. We need to make sure that our system can really provide the necessary protection. The same for the healthcare workers. And this is the third question I think we have seen in Africa during the West Africa, Ebola outbreak, that more than 500 health workers died. Today in Uganda, we have seen also health workers dying from Ebola Sudan. And capacity building training is so critical. But unfortunately in Africa, we have so many informal health structures. When we were dealing with Ebola in Congo, in the city called Beni, we identify more than 300 informal and traditional health posts. So making sure that we know exactly who is providing this, the health service and train them appropriately, making sure that they have also the right equipment, from triage to clinical management will be critical. Thank you.
Thanks, John. I'll respond to 3 points. First, to the first question from the journalist. I actually was on and still am on the Global Preparedness Monitoring Board that AS co-chaired, and was involved in writing that 2019 report, which said in essence that we were incrementally better prepared for responding to the next Ebola outbreak, but we were still very unprepared for a fast-moving respiratory outbreak. And 5 months after that report, COVID emerged. We've been as a global preparedness monitoring board, trying to get the attention of states parties. And I think this is where some of the things Ahmed mentioned about the ongoing negotiations of the intergovernmental negotiating body, whether for a pandemic treaty or a framework convention, which will ultimately have to deal with some very complex issues around access and rapid reporting, sharing of benefits, and countries that sound the alarm not being penalized because of non-evidence-based restrictions in travel and trade, which hit their economies very badly. And I think we saw a lot of that here in Africa. So I think we need to come together as a global community. And I think these negotiations that are currently underway, and ultimately having a high-level meeting at the UN General Assembly in September focused on pandemic preparedness and response, hopefully will be one step to getting the attention of states parties in terms of listening to this reality of the cycle of panic and neglect. The second thing, which builds on my initial comments and to the comment from the gentleman on the left, is we need to spend more on health sector, where we've been barely supporting it. We've often been relying overly on out-of-pocket payments, but we also have to recognize the current economic realities. And while we're advocating to spend more, we need to spend better. And by that, I mean that I think we need to look within national budgets about the relative proportion of the health sector funding that goes to primary healthcare versus expensive tertiary healthcare, which is often located in capital cities and captive to the elites. Because it's the primary healthcare system where you'll see the first signals of an emergent infection. I think it was Oz who said that, you know, outbreaks begin and end in communities. And so the points that Professor FAWOLE made about the community engagement in preparedness is actually quite important, because if we have a strong primary healthcare system, we will begin to see the signals sooner so that we can respond. And that gets me to the third question about artificial intelligence and the role of predictive analytics. I think that is very much a part of our future preparedness framework. But in order to have predictive analytics, we're going to have a broader set of signals. We're going to need to look carefully at the One Health approach so that we're beginning to see viral evolution and the emergence of pathogens in animal populations before they cross over. We're going to need to, as you know, as working in artificial intelligence, it's often about finding the weak signals that amidst a lot of noisy data. Right now, we have very noisy data. In many places, we have no data at all. And so, as we saw back with the Ebola outbreak in West Africa, an outbreak can occur and go unrecognized for some time. So if we can build a stronger primary healthcare system and build a set of predictive analytics, take advantage of the advancing field of artificial intelligence, but it's got to be served by data that comes timely so that the analytics can actually tell us that there's a signal so that we can respond earlier. So I think we've got a lot of work to do. I think we should do it quickly before people begin to talk about COVID in the past tense and go into that neglectful part of the cycle of panic and neglect. But thank you all for your questions. Thanks.
Thanks, yes. So let's go to Professor FAWOLE. If any of the comments that you heard from the floor stimulate any reaction from you, then we end with Ahmed.
Okay, my interest is in the question about maintaining routine services in the midst of pandemics and epidemics, because these things continue to happen. It's a question of when the next one happens. So what I would suggest and what we found very beneficial was monitoring trends. So even when epidemics happen, we mustn't close shop completely, which is what happened in some places during the lockdown. So we must continue to monitor trends to let the data guide us into the next and appropriate public health action. Thank you.
Good. Please go ahead.
Thanks, John, and thanks to all those who've asked those very important questions. Governments actually listen the two challenges that I will say make it sometimes difficult for governments to react from our experience is, are we speaking a language that they understand so that they may be able to respond to the issues that are being raised for them to be able to listen. Politicians by and large have a half-life. The administrations are not that long. They range between 4 and 7 years. And it's important that whatever we are putting on the table is within the interest, if you want, of that particular administration to be able to respond to within that timeline. If we make it very abstract and long-term, then very often there's no response, and therefore we may see that they do not listen. But when we have the opportunity of them listening, like during the pandemic, then we really need to ensure that we pass the right messages that are going to last beyond that particular pandemic. Now, keeping an eye on routine services, my colleague from ARC, is based on purely monitoring your routine services. Then you'll be able to know whether it is going down or it is going up or it is remaining the same. If you don't have good data that can be able to guide your decision whether it is going down or it is going up, then you cannot be able to respond appropriately. So the two things that I think we need to do is to get very good monitoring of all aspects of the health system, so that if there's going to be a change, we know quickly and we are able to respond. The second is goes to what I'd said earlier around having a standby resource that you can be able to use to avoid disrupting the usual routine health services. If you don't have that standby resource, then inevitably you'll end up using the routine health system, and it will disrupt your routine services. So if we monitor and we have a standby resource, we can be able to address these issues in a more effective way. In fact, as Chris was saying, outbreaks start and end in the community. If we have a strong mechanism of identifying outbreaks, if you want, or health events at the community level, we can arrest it before it becomes a bigger outbreak. That way, saving the whole health system. Training of frontline workers. This is one of the bigger challenges that we have, particularly here on the continent of Africa. And because health services are provided, as Socé was explaining, by a diverse group of providers, and not all of them subscribe to a lot of what we know is protective tools and mechanisms. Now, as Africa CDC, what we have been doing is, at the beginning of any outbreak, one of the very first things we do in terms of response is infection prevention and control. We go into the outbreak area, and at least the formal health services institutions, we do training there, because you cannot be able to provide a service unless you're protected. And this has been quite effective in ensuring that the healthcare workers have the knowledge, and we provide the initial tools and encourage the government to be able to take that over so that they can continue to provide the services without exposing themselves to any particular outbreak. But the challenge still remains when that index case comes. If the health system is not stable, meaning that the health workers are not appropriately trained and given the right tools, then the health worker is going to get exposed. And most of the recent outbreaks that we have seen, it is that index case that actually gives a lot of challenges to the health workers. They get exposed, and like in the case in Uganda, we lost quite a few, but it is out of the index case. So the health system needs to be strengthened to the extent that it is able to protect the health worker by addressing the index case. Therefore, if you have a health system that is not well resourced and you have health workers that are not well trained from the beginning, you will get trouble with that index case. If you have a health system that is well designed and is stable, then it can be able to protect the health workers by the index case. In as far as technology is concerned, this is the way forward. If we do not use technology, we cannot be able to have faster results. We cannot be able to have better results. We need to go down the technology way, and artificial intelligence is really key to this. And as Africa CDC, we've started our digital health area of work, and we are ensuring that as we grow that area of work, we are working together with our member states so that they too can be able to utilize technology in ensuring that we get information quickly and we analyze it fast, and we are able to respond in a way that protects the public effectively. Thank you.
So we have 15 minutes to go, and I will stick with the panel and ask that we try to manage the 15 minutes with very specific and short answers to this set of questions. And starting with you, Ahmed, I'm reading here, I just Googled and about some of the things that you have been championing. And on the 29th of September, the Africa CDC published a call to action for Africa's new public health order. Can you really tell us what that is? I think we've read all of that, but it would be good to hear from you what that new public health order entails.
No, thank you. The new Africa's new public health order is premised on the fact that particularly in health security, we have been doing the same things and getting the same results, particularly here on the continent. To be able to change the results within the health security space, we need to do things differently. And the new public health order has 5 pillars where we are persuaded that if we do these 5 things differently, then the results are also going to be different. The first is strengthening institutions on the continent. This is continental level institutions like Africa CDC, the Africa Medicines Agency, national level institutions, national CDCs, national public health institutes. When you have an institution that is dedicated to health security, then you find yourself identifying your problems early and responding to them effectively. So strengthening of institutions is the first pillar. Second is workforce. We need to have a workforce that is well trained in adequate numbers, given the right tools that we've just been discussing, and then we deploy them to the right places when there is an outbreak. In this way, we will be having an opportunity to protect the health system while still addressing a particular outbreak that may have come within the country, within the continent. So strengthening our health workforce is the second pillar. Third is local manufacturing. During this pandemic, Africa was the problem started way before. The HIV pandemic, when we lost so many people on the continent of Africa, though there was therapy, it was a very painful example. During COVID, vaccines, we were right at the end of the queue. We were right at the end of the queue for PPEs as well in the beginning of the pandemic. So getting a manufacturing enterprise on the continent so that in case there is a large outbreak, we are able to access the right tools quickly is a priority for us here in Africa. And that is the third pillar of local manufacturing for everything, from the simplest to the most complex health products. The fourth is domestic resources. That Africa must, and we have started, must develop its own domestic resources, including money, but also expertise, institutions, so that at the beginning of any outbreak, we can be able to bring together the local resources to respond. In case it overwhelms us, then we can ask for support from outside. And I think the example that we were discussing earlier with the Gates Foundation providing support right at the beginning of the pandemic is very telling, that if you have resources at the beginning, then your planning and response is better organized rather than when the resources come later when the outbreak has already expanded. The fifth pillar is partnerships. We know we must do this on our own, but we are also clear that we don't need to do it alone. We need to learn from others. We need support from friends of Africa. And so the partnerships that we are talking about in Pillar 5 are partnerships that are action-oriented, giving results, and also partnerships that are based on African priorities. And we believe that implementing effectively the new public health order is going to change the way in which Africa responds to outbreaks. It is going to change the results of any large-scale outbreak that may occur on the continent. This is the new public health order.
Professor FAWOLE, I think you heard Dr. Ahmed explain the new public health order, and one component was the workforce. And if we have to have a credible workforce, the university, especially schools of public health, will play a very critical role in that. How do you anticipate going forward, given what you just heard, to meet that gap and learning the lessons from COVID and to prepare the next workforce from the public health perspective?
Thank you very much, moderator. And just to add again that the universities certainly hold a crucial position when it comes to generating and disseminating knowledge. And the university trained the scientists and the personnel that worked on the COVID-19 outbreak. And we're not hoping for it, but there would be other epidemics and pandemics. And the universities, again, would train the scientists and the public health practitioners that would work on that next outbreak. So the universities are very, very important. As regards the 5 pillars that was presented by the director, I'd like to say that the universities are already rising to the challenge. And my university, the University of Ibadan, Nigeria, was a beneficiary of an EU Africa CDC program to train 15 epidemiologists on disease outbreak and response. These students were students from West Africa, and we have 5 from other African countries, 10 are from Nigeria. They have commenced their first semester of training, and their training is learning from the experience of COVID-19, in that it's not just classroom-based. We're ensuring that they have a lot of field experience, a lot of outdoor training. The curriculum is ensuring that they are doing field activities and hands-on with their training. So we're already a beneficiary of your policy, and we're working together in tandem. So this program too has smaller classes. There's a peer learning, and the content is reduced. And another thing that the universities need to do following this epidemic is that we have done that, not only us in UI, many African universities rose to the challenge, is to move from physical training to hybrid and virtual training. Of course, there are challenges with this because connectivity is always an issue, and also getting older faculty to learn to use some of this software, but this is some of the changes and reforms that are certainly necessary and which we're doing. And another one that is crucial to what the Director of African CDC has mentioned is partnerships. Following the pandemic, that is a lesson that we have learned, that we need to work in partnership with other organizations. And this partnership is at many levels: partnership with implementing partners, WHO, Global Fund, UNICEF, and they certainly supported, and we worked together to train subnational health workers during the pandemic. Then partnership with other African universities. We have partners, we did research together with other universities, including Senegal. Professor Sek and myself were in some research groups together where we were working on ways to respond to the pandemic in our country. So there were many cross-cutting research that we were able to do: Nigeria, Senegal, DRC, and Uganda. Then community partnerships, because the community trusts the academics to a large extent, at least in my country, more than the politicians. So when we engage the community, then they're likely to, they trust us, and then they go with what we say, and then we bring about change better with them. So these are some of the things that I think would be crucial, because we know that the universities, both the students and the faculty, have a huge role to play. One last example I like to give that we did in my university was our postgraduate students, Dean School of Public Health. So the postgraduate students really supported in the COVID-19 response. They carried out surveillance at our ports, the busy ports, the airports. They were there working, and they were supported to do these activities, to do surveillance at busy ports, do tracing of contacts, contact tracing. They screened international travelers, and they conducted risk communication with passengers coming in and going out of the country. And they monitored persons of interest. So our postgraduate students were very hands-on. In fact, throughout the pandemic, we weren't in our homes, we weren't in lockdown at all. We had to support our students on the field. And the faculty too were not indoors either. Faculty trained the rapid response teams at subnational levels to rise to the challenge and to respond quick to changing trends. So the university certainly has, and we will work together in tandem with other international and global partners to ensure that Africa moves forward in its bid to improve public health. Thank you.
So, Socé, let me turn to you. You heard from the acting director of Africa CDC touch on access to vaccines. And COVAX was a mechanism that was established during this pandemic, the COVID. And it would be very helpful to hear your views on how that process goes forward and how that squares in the theme of this meeting today, which is universal health access, because that was we also have an access issue there. If you can just describe your reflection on what it represented and the intent of that, and how can that fit into universal health coverage?
Merci John. Je pense que c'était une excellente idée de lancer l'initiative COVAX, donc à laquelle aussi tu as largement contribué en étant directeur d'Africa CDC en ce moment. Il était important pour les pays les moins favorisés d'avoir accès aux vaccins, et le seul mécanisme qui permettait de le faire en ce moment, c'était à travers COVAX. Bien entendu, il y a eu beaucoup de leçons aussi à apprendre de COVAX, parce que les pays donc les plus nantis se sont servis en premier, et il était très difficile à un moment donné d'atteindre même les 10% de couverture vaccinale dans les pays les moins nantis. Et je pense qu'à partir de ces leçons, maintenant, l'indépendance vaccinale d'un continent comme l'Afrique est essentielle, et tout le travail que l'on voit aujourd'hui avec l'Institut Pasteur, avec d'autres pays qui investissent la production de vaccins, nos pays africains doivent fédérer leurs efforts pour être sûrs que nous pouvons produire des vaccins de qualité, des médicaments de qualité, et qui peuvent aussi donc concurrencer les produits qui viennent d'autres parties du monde. Et cela demande un investissement en amont qui nous permette donc de faire de la production locale, mais aussi de nous assurer que la qualité est assurée à tout moment. Et le marché intra-africain et le marché mondial sera ouvert dans ce cas. Cela demande beaucoup de travail, s'assurer que nos produits sont à la hauteur de tous les produits qui existent dans le monde. Et je pense que c'est la seule façon d'anticiper sur les prochaines pandémies, mais aussi sur les problèmes de santé que nous vivons tous les jours. Et je suis heureux de voir que l'Institut Pasteur reprend la production du vaccin contre la fièvre jaune, qu'ils avaient arrêté à un moment donné parce que le marché était limité, mais je pense qu'il y a beaucoup d'autres vaccins comme la rougeole, la rubéole, et nous ne devons pas nous limiter donc au vaccin contre COVID, parce que le prochain risque ne sera pas certainement le même virus. Donc, il est important d'anticiper dans la production et l'indépendance vaccinale. Merci.
Thank you, Socé. Since you touch on vaccine production in Africa, before I go to Chris, I would like to put one of our colleagues on the spot here, the director of the Pasteur Institute. You talked of the yellow fever vaccine and COVID, and there's no one better place in this room than Dr. Madusa to react to what you just said about vaccine manufacturing in Africa, and where are we with that? What are the prospects of, I mean, where do we go from here so that we end up with Chris, and then my co-moderator will summarize the meeting, and then we close. So Amadou, sorry for putting you on the spot. I mean, what is the Pasteur Institute doing? What is the philosophy behind vaccine manufacturing at the Pasteur Institute? Please, if the microphone can go closer to micro.
Merci beaucoup, John. Alors, actuellement, l'Institut Pasteur de Dakar est dans la dynamique qui a été initiée par Africa CDC quand tu étais encore, John, d'un partenariat pour la production de vaccins en Afrique. C'est-à-dire de bâtir un certain nombre de pôles, dont un en Afrique de l'Ouest qui va produire avec une vision continentale de façon à ce qu'à l'horizon 2040, nous ayons au moins une capacité locale de produire 60% des vaccins. Juste pour rappeler qu'aujourd'hui, on en importe 99%. Alors, dans cette perspective, l'Institut Pasteur de Dakar s'est lancé dans la mise en place d'une plateforme intégrée dans laquelle il sera possible de produire des vaccins à partir de technologies ARN messager, des œufs ou de la culture cellulaire. Et avec une capacité de 300 millions de doses, et nous avons initié donc un projet il y a un peu plus d'1 an et demi, qui est maintenant peut-être à 70% en termes d'infrastructure qui est avancé, et pour lequel nous sommes dans la dernière phase de discussion d'un certain nombre de partenariats pour faire des vaccins pour des pandémies comme la COVID, des vaccins pour justement faire de la routine et des vaccins pour les épidémies. Et cela, on le fait grâce à un partenariat très large qui est d'abord financier avec des institutions comme AFC, la Banque mondiale, DFC, les partenariats bilatéraux comme la France, l'Allemagne, l'Union européenne et la Banque européenne. Un partenariat aussi technique avec des institutions comme CEPI, et aussi un partenariat avec des institutions philanthropiques comme Gates ou Mastercard. Ce qui est important, c'est que avoir des capacités justes de production ne suffit pas. Il faut aussi derrière une capacité à avoir les hommes qu'il faut. C'est pour ça que c'est très important tout un volet de Human Capital Development, mais aussi tout un volet aussi de recherche, parce que c'est grâce à ces recherches que nous allons demain avoir des vaccins qui sont spécifiques de l'Afrique ou des vaccins qui vont prendre en charge justement les priorités africaines. Juste pour donner un exemple, nous avons donc lancé un grand programme de recherche et de tech transfert grâce à un soutien de la Fondation Gates pour justement rendre disponible la rougeole et la rubéole comme vaccin dans les années à venir, parce qu'aujourd'hui, il y a une certaine tension dans ces vaccins. Dans le domaine du Human Capital Development, nous sommes en train de travailler avec des partenaires comme Mastercard pour trouver une solution pour que les grands besoins de l'Afrique puissent justement, dans les différents métiers du vaccin, être résolu. Et donc, c'est un projet qui avance bien. On espère que dans le courant de l'année prochaine, nous pourrons en voir la fin. Mais un dernier élément que je voulais signaler et qui est important dans la vision qu'a Africa CDC, initiée depuis le début par toi et continuée par Ahmed, c'est vraiment que ce travail doit se faire dans un contexte de concertation. Aujourd'hui, il y a plusieurs projets en Afrique dans ce domaine-là, et se concerter sur quel vaccin produire, comment gérer le marché du vaccin en Afrique avec les partenaires comme Gavi, COVAX, etc., est vraiment quelque chose d'essentiel, parce qu'il ne s'agit pas juste de construire et d'avoir des vaccins. Le marché est essentiel, et s'assurer que nous le servons dans un contexte de collaboration et non de compétition en interne ou à l'extérieur me paraît très important. Merci.
So, Chris, the last word comes to you before we go to the co-moderator to conclude the session. You just heard from Ahmed, the new public health order emphasizing partnerships. And I think the underpinning of your foundation's work is partnerships. You also heard extensively from Amadou about the work he's doing in vaccine production, which is really rallying around partnerships. Can you just reflect on how your foundation views partnership And also just add a B section to that question about your meeting tomorrow, which is the meeting that the head of state of Senegal is presiding tomorrow on immunization and how partnerships can help advance immunization as part of universal health coverage.
Thanks, John. Well, I think, as Amadou just said, basically everything that we do to get to that new public health order that Ahmed outlined is going to require partnerships. And the Gates Foundation, everything we do is really through partnerships, working with a vast array of partners to get some very ambitious global health and development goals accomplished. We're very happy to be supporting the Institute Pasteur here in Dakar on that work that Amadou described on measles and rubella. That's bringing in also new technologies. I think if we think forward, we have to think about, because a new public health order doesn't happen by flipping a switch. We're going to have to build our way there through the 5 pillars that Ahmed described. And we're going to have to strengthen institutions. We're going to have to be more creative. We're happy to work with the Institute Pasteur. We're also working with BioVac in South Africa on the cholera vaccines. Part of the future is building for the vaccines we're going to need that are currently in short supply: measles and rubella, cholera. We have a partnership with Aspen on a tech transfer for 4 different vaccines, including HPV and respiratory syncytial virus. So I think we have to, be aware of where we want to go and where science is going to help us, because technological innovations in vaccine production and artificial intelligence and others are going to be assets that help us get there faster. And so we need that partnership. And to your comment about tomorrow, we're very happy to be co-hosting with President Macky Sall in his capacity as chair of the African Union, what is really a follow-on to a critical meeting that the African Union convened in Addis Ababa back in 2017 to set out an ambitious goal for improving immunization. And it was reflected in the Addis Declaration. As many panelists have said, we've had a setback to routine immunization because we had a very constrained workforce that needed to do double time on rolling out COVID vaccines in as quickly as possible. So as Socé said earlier, we have 5 million additional 0-dose children. We need to regain those gains, because one of the key things that's at risk, in the dark days of the summer of 2020, while the pandemic was raging, one of the few really positive things was that the World Health Organization certified the Africa region free of the wild poliovirus. An incredible achievement. There's only one region left. We've only seen cases of wild poliovirus transmission endemically in Afghanistan and Pakistan for the last 5-6 years. But because of some of the reductions in routine immunization coverage, we did have a reintroduction about 9 months ago in first Malawi and then Mozambique. The African continent will be vulnerable until we succeed in Pakistan and Afghanistan to the reintroduction of poliovirus. And we'd hate to see the certification of Africa as a wild poliovirus-free region to be at risk for that. The way we eliminate that risk is by redoubling our efforts to improve the routine immunization coverage, as well as introduce new life-saving vaccines as they become available, as we build this capacity for greater vaccine independence. So the forum tomorrow is really about reasserting the goals, those ambitious goals the African Union set back in 2017, and to think about how we garner the political commitment, which we know is absolutely essential for prioritizing immunization as one of the key essential health services as we go forward into this recovery from the COVID outbreak. So we're very pleased to be co-sponsoring that with His Excellency. I think that's exactly the kind of political leadership we need to begin to regain the gains in immunization as well as other essential health services. Thank you.
Merci beaucoup. À présent, nous sommes arriver au terme de notre panel qui a porté sur l'impact des pandémies sur la couverture sanitaire universelle. Au décours de ces différents échanges, si on devrait retenir des mots, des messages clés pour que demain, que nos États soient encore plus prêts, je retiendrai ces deux mots que voici. Le premier, c'est qu'il faut être bien préparé. Et le deuxième mot, c'est qu'il faut bien organiser la réponse. Mais tout cela doit nécessiter que nos États renforcent leur système de santé. Et le renforcement du système de santé revient à améliorer les 6 piliers que constitue le système de santé. Et ces 6 piliers, on les a abordés quand on a écouté les différents panélistes, tournent autour des ressources humaines. Il faut des ressources humaines compétentes, qui soient bien formées pour faire, n'est-ce pas, ce qu'ils doivent faire. Il faut des soins de qualité qui doivent être maintenus, quel que soit l'état de la crise. Il faut aussi un financement soutenu, puisque si on ne finance pas assez la santé, on l'a dit, alors on ne pourra pas arriver à détecter à temps, n'est-ce pas, les épidémies. Plus on met moins d'argent dans la préparation, on sera obligé de mettre beaucoup plus d'argent dans la riposte, comme on l'a dit, donc le retour sur investissement. On a aussi insisté sur l'approvisionnement en médicaments, en vaccins, en technologie. Donc, il est important de tirer les leçons de cette pandémie, encourager l'indépendance vaccinale, mais aussi la production locale au sein de nos États africains. Il est aussi extrêmement important, le 5e pilier, de renforcer nos systèmes de surveillance épidémiologique. On n'a pas beaucoup parlé des laboratoires, mais les laboratoires jouent un rôle extrêmement important parce qu'on a vu ici, au début de la pandémie à Covid, il n'y avait pas beaucoup de pays africains qui étaient capables, par exemple, de faire la PCR. Et même au sein d'un pays, il n'y avait pas tous les laboratoires qui étaient capables de faire la PCR. Et après, on a vu toute l'importance de la surveillance génomique et je pense que aussi, ça, c'est une leçon à tirer. L'autre et dernier élément, qui est le 6e pilier, c'est ce que Chris disait tout à l'heure, il faut que nos États renforcent leur leadership, le management pour pouvoir, n'est-ce pas, arriver à mettre en place des systèmes de santé pérennes, résilients, ce qui nous conduira à pouvoir aller accélérer la marche vers la couverture sanitaire universelle. C'est ces mots que je voudrais vraiment remercier tout un chacun et déclarer close cette session qui a porté sur l'impact des pandémies sur la couverture sanitaire universelle. Je vous remercie de votre attention.
Pour la 5e année consécutive, le Forum Galien Afrique se déroule en terre sénégalaise du 6 au 9 décembre 2022. Le Forum Galien Afrique offrira une plateforme d'échange exceptionnelle autour du thème « Accélérer la marche de l'Afrique vers la couverture sanitaire universelle ». Placé sous la présidence effective de son Excellence M. Macky Sall, président de la République du Sénégal, le Forum Galien Afrique réunira des experts scientifiques des secteurs de la santé, de l'économie, de l'environnement, d'éminentes personnalités politiques et de la société civile, d'anciens récipiendaires de prix Nobel, des universitaires et des centaines d'étudiants en médecine et pharmacie, ainsi que des jeunes innovateurs. Cette 5e édition du forum, avec 1500 participants, sera organisée en format présentiel et virtuel avec, du 6 au 9 décembre 2022, un forum des jeunes, un forum des femmes et un forum scientifique. Le vendredi 9 décembre 2022 se tiendra une cérémonie en présentiel au cours de laquelle, pour la seconde fois, le prix Galien Afrique, qui consacre la recherche, l'innovation, la santé et la technologie, sera décerné. Du 6 au 9 décembre, le Forum Galien Afrique fait de Dakar la capitale africaine de la santé, de l'innovation et de la recherche.